My name is John Mills. I'm on the staff of CCHF. Let's start our session with a word of prayer, if you don't mind. Come, Lord Jesus, come into this room as we are discerning maybe our next step in ministry or how you are calling us to do work with your children. Lord, we just pray for wisdom. We pray for good ideas and for ways to encourage everyone in the room. Lord, be with us as we travel home, because time is near for that. And keep us always in thy will. In thy name we pray. Amen. So, I'm John Mills. I have been doing this work for a long time. I've been working in our sector for 30 years with lots of different roles. And so the one that's most important to what we are doing right now is that for 15 years I was with Empowering Church Health Outreach, which was a nonprofit organization that sole purpose was to walk alongside groups that are starting free and charitable medical clinics. And so we offered no-cost consulting services, tools, and resources that made the process of starting a clinic easier. And what I really want to emphasize right now is that this is not an easy journey that you may be contemplating. It's hard. There's a ton of work involved. But what I hope to cover in our time today is some of the ways that you can make the journey easier for yourself if you want to really go down this road. And so, I've been blessed to be the primary consultant for 35 or so New Start clinics, and then helped another 30 or so as the supervising executive over other consultants that have been working to help start clinics, again, during that 15-year period. And we also help clinics grow. And so if you're a small clinic doing 1 or 2 days a week of work and you have the vision of growing to a larger footprint in your community to sort of make a bigger impact, then a lot of what I'm going to cover is relevant because, everything's about relationships. And so a lot of what I'm going to talk about is about people and the resources of people in your community and how you gather them around yourself. CCHF, I mentioned ECHO. ECHO closed in 2022. I was really sad about that. And so I've come along with CCHF. Steve was just a pastor to me when I was going through that sort of letdown that my organization I've been working with for 15 years, I was really passionate about, closed, And so I had that sort of Jericho Road moment where it was like, oh God, what do I do now? And Steve prayed with me and listened to me vent and complain. And then said, well, we really need to figure out a way to get you on board with CCHF so you can continue to do this work. And so I've been very blessed to be able to do that. And so through CCHF, I can work with you at no cost to help you get to where you're going. This may be the most important question that I'll ask. And so why are you here? What is your feeling about, I'm being called, maybe? Is that it? I sense this tug on my life to do more, to serve more people. So what are you feeling? What's bubbling up in you that makes you think that maybe starting a clinic is the direction that God is leading me? And I'm going to talk about vulnerability a lot in this session, but is there anybody willing to sort of share that voice that they might be hearing that says, you can do this, I'm calling you to do this in your community?
I think our situation is we're in Rochester, New York, and our church had engaged in a lot of outreach to under-resourced in our community through food distribution, and out of that, like the food distribution grew, and we had a building project that accommodated that better with daily food distribution, and our pastor has a vision for medical outreach also being a component of that, and so that like really resonated with me. I went back to school, I got my MP, I pictured that, let God use me however He wanted.
Mm-hmm.
In that, so there's an excitement but we're in a suburban setting. Half of our suburb is quite affluent, and the other half has more urban characteristics and is quite poor. So that's kind of where we are. That's our why. We see a need. We have excitement toward it.
Okay, great. Anybody else want to share what they're feeling called to do? Yeah. I'm going to have to bring the microphone to you because you're in the very back.
Where I'm from, I am partnering with a nurse practitioner to start our own community clinic. We want to serve single moms, and we want to provide tattoo removal to get people back into the workforce. Mm-hmm. So that's part of, there's a lot of folks who just neck or
Sure.
face. So we want to help folks in that manner.
Okay. Interesting, right. Who is it? Father Gregory out in Los Angeles tells a fabulous story about, having an individual that was in a gang come and access the resources of his ministry, and on his forehead was F the world, and it's like, I can't get a job, Father Gregory. Why can't I get a job? And so that sort of opened the door to maybe tattoo removal is something we should explore. And so there are so many ways that you can, serve the body of Christ. And so I talk a lot of people out of doing this work. And so the reason is because it's very hard. And there's a lot of really good organizations already around. And so, if you're in this discernment phase about, should I start my own thing, I want you to pray hard about it. I want you to invite others to pray with you about what you are discerning. And frankly, I want you to explore what ways you could come alongside an existing Christian organization and be a provider, be a volunteer, be a staff person, because the duplication of services in the same community is a thing. I mean, you may potentially be competing for the same volunteers or providers or funding, and so I'm a burning bush kind of guy, and that's one of my problems. Is I pray and I say, I gotta have a sign here, God. And I've experienced call. My family was called to the mission field. And it wasn't a burning bush that we saw, but it was just a thought that I could not get out of my head for 18 months about there's this need in this community that I've been to with these pastors that are really in need, and I have the skills and I have the resources to be able to make a difference. And I just couldn't get that thought out of my head for a long time. And then I, actually talked about it with my wife, and she didn't want a divorce. And so, that was sort of the open door for us to explore, okay, how do we move our family to a foreign country? How do we homeschool our kids? How do we do all the things that we had to do? And so I'm I have experienced that real tug on my life towards doing something around ministry. And so I encourage you to pray and to invite others to pray for those open doors to appear for you, and to pay attention if the doors are closed, if you're continually bumping into resistance, then to really pray harder and to see if the vision that you've got is God's vision or if it's your vision. And that is one of the hardest things as a Christian that we deal with, is knowing whether our plan is also God's plan. So pray. So what I want to cover during our session today are four or so main points. And it's building your team, it's starting a new entity, it's finding your location, and raising your funding. And so I really can't stress strongly enough how important it is for you to have a team of people around you as you are undertaking this work, because it is hard work. And like I said, I've worked with a lot of individuals that are generally our first point of contact is who I would call a visionary champion. That's the person who's got this feeling that they need to do something. And so I've had a lot of conversations with individuals who are feeling called to make a difference in their community. And those that took my advice and built a team around them to do this work together had a much higher success rate of actually getting a clinic open than those that did not and tried to do it all by themselves. And so it's being vulnerable. That's really the key, is you've got to assume a position of vulnerability and ask people to help you. And, most of us are bootstrap kind of people, and we're successful in other things, and we get the job done ourselves. But this is a realm that's different. It's more complicated, and it's harder. I mean, it's not like a church starting a clothing closet or a food pantry. Those are all important ministries. But we're talking about delivering health care to a community. And so it's just a more involved kind of undertaking. And so it's really important to tell your story to people and invite them to come alongside of you. But you need to have, specific skill sets of people around you. And so it's really important to know, what do I feel comfortable doing? What am I bringing to this equation? But then, who else do I need around the table? And so, we've got resources that sort of outline that the folks that we think you should have around the table, whether, it's a CPA, whether it's an attorney, whether it's a builder or a realtor, because you're going to have to find somewhere to be probably. Somebody that's skilled in communications to share your story. Obviously medical people, and dental if you're going to provide dental counseling, if you're going to have, so sort of like envision what you're going to do, and then find someone from every one of those disciplines that you think you're going to be involved with, and invite them to join your, I call it planning team, to join your planning team, because you're going to be that's going to be the group of people that are going to be sort of your core support during the 12 to 18 to 24 months that it's going to take you to get this project off the ground. And so, it's really, I really believe that that if you can find people that are skilled to work in their skill area, things are going to get accomplished much faster than if you try to learn how to do something. How do you build a website? Oh, okay, I can go on YouTube and I can figure out how to do all that. But if you can find somebody that's built websites, and say, I need help with this, then that's going to take a lot of pressure off of you and hopefully give it to somebody that is skilled in that area. And so every team needs a leader. And so you need to identify somebody that's going to be the project leader for this project. And it might be you, or, you could be what I call the visionary leader. You could be the one that's really feeling called to this, and you're the spokesperson for this group, this project in your community. And unfortunately, many visionaries don't have the detail skill set. A lot of visionaries need detail people around them because they have these great ideas that are spouting out and coming to their head, and they're, if you've ever worked for a visionary, man, it's pretty frustrating sometimes because they're just like, hey, here, we're doing this right now, and you want us to do this and this and this and this, and so understand your strengths going in and try to build people around you that can complement your strengths. Settle in. This may take a while. 12, 18, 24 months is the norm, because there's just some hurdles that you've got to get through along the way. CCHF, Christian Community Health Fellowship. We're going to default to, let's see how we can engage the faith community where we live. And so you guys mentioned that your church is considering this. That's fabulous. And so some of the benefits that the church can receive from being involved in the creation of a clinic is, obviously if you read the New Testament, there's a fair amount talking about health care. It's just Jesus' healing of the people. And so hopefully your church sort of understands that there is a place for the church in the healing of individuals. Not every church understands that, but sounds like yours might. And so these kinds of projects also provide a pathway to get people out of the pews and get them involved in touching and loving and being involved with the community. And pastors generally are fans of that. And so churches also have potentially space that can be used to house the clinic as it's getting started. We've worked with a lot of clinics that initially started on the campus of their church, because there's a lot of buildings and things that aren't used 6 days a week. They're really busy on Sunday, but they're just not really used during the week. And so there's potential for that church to be the home for your clinic. And there's potential for financial support, either from the budget of the church or certainly from the attendees, the congregants can come alongside. We helped start a clinic in Irving, Texas, and the church was 8,000 members, which is, that's a good sized church. And the clinic raises their annual budget with one love offering from that congregation one Sunday a year. That's astounding if you think about it. And it's very unusual. But, it's just one of those things you learn and you go, wow, that's cool. And so, don't be afraid to get up in front of your congregation and tell your story of what you're doing. Because people give from multiple pockets. And, hopefully your pastor will understand that and not be threatened by a potential ask for financial support that's different from the gift to the church. And so those are all conversations that you're going to need to have with the faith community if you're going to be involved with them. But it's also important to realize that there's some challenge if you're going to be a ministry of the church, because I really believe the clinic needs to have its own separate entity to protect the assets of the church, because the incidences of a malpractice claim in the free and charitable clinic realm are very low, but they're not zero. And so every kind of firewall you can put in place to protect the assets of the sponsoring church is important. Also, you know, a Baptist church might not write a check to the Methodist church if it's just a ministry of the Methodist church, but they're more likely to support an independent not-for-profit, even if it's on the campus of the church. And so, you know, just lots of things to consider. And so for the clinic, I've mentioned potential space. A lot of in-kind support can happen. There's, you know, administrative staff in bigger churches that could be tapped into to help you as you're a fledgling organization getting off the ground. And so consider not only your faith community, but also the broader faith community. And so tell your story to as many people of faith as you can. This, again, that vulnerability piece, that being vulnerable, telling the story of your vision even without any assurance that it's going to happen. Because, you know, at this point, you're a concept, you're a vision. I always tell people it's a whole lot easier to raise money when you're serving people than when you're talking about serving people. And yet you've got to get that word out even before you begin serving people. So who are you called to serve? So many states, I think this slide was made in maybe 2015, or that graphic. And at that time, not as many states had expanded Medicaid. We still have, 15 states maybe that haven't expanded? And so in those states, particularly in the southern part of the country, there's an overwhelming need. The number of uninsured folks are just, you know, Texas and Florida are competing every year. Who's got the most uninsured? And so, you know, in those states, there's a tremendous need. But it's really important to understand this graph, because the ACA was predicated on 100% of the federal poverty level was sort of the beginning point for coverage. And then it went up to 138% of the federal poverty level. But for those of you that are aware of Medicaid eligibility requirements in your state, many times the income threshold for Medicaid eligibility is less than 100%. And so there's this gap where there's no availability. You can't get ACA coverage, subsidies. You make too much money for Medicaid. And so there's just this people gap that is really pretty astounding. And those states that have recently expanded Medicaid are able to sort of come alongside and fill that gap. But determining whether you're called to serve just the uninsured or maybe the underinsured, which is a category of folks that, you know, might be able to have an insurance policy, but it's got such a high threshold for a deductible that they really have catastrophic health care coverage. They don't really have primary care coverage. And so Could your clinic serve those folks? And these are conversations to have with that group of people that you're building, because you've got to be able to tell your story about who you're going to serve. And you got to do your demographic research to identify that. Yep.
Are these numbers based on Medicaid expansion?
Yes. Yes. And so, you know, the Medicaid expansion picks up the no covered folks. And so, you know, that was one of the big arguments for the states that didn't do it initially, was we've got all these people that are in this gap that really can't get anything. And so there's also, you know, marketplace insurance, which doesn't pay well. And so the models that I'm going to talk about in a little bit are, there's a whole spectrum between free and federally qualified health center. And so, you know, the folks that are in the left side of this gap are free and charitable clinic potential patients. Those that have some kind of insurance are potential patients for the hybrid or the Medicare, the FQHC. So again, as you're discerning, you've got to figure out what your model is going to be. And so there's a spectrum in our world. A free medical clinic is sort of the left boundary, and there's no expectation of cost of money changing hands for care delivery. And there's some benefits to that, and some pros and cons, basically. The pro is there's a very low administrative requirement. You know, you don't have to figure out how you're going to handle money. You qualify for malpractice coverage through the Federal Tort Claims Act, which is pretty huge as far as, you know, the benefit there. It's total immunity from prosecution, because the federal government is the defendant if there's ever a claim filed. And it is a federal program. There's some hoops you have to jump through to qualify for it, but they don't care if you're a Christian group. They don't care if you're praying with patients. They don't care if Christ is in your name. And so, but you can only get that coverage if you are a free medical clinic. So once you take the step to the right where there's an expectation of a charge, $10, $20, $30, sliding fee scale, any fee for service, then you are disqualified from the free clinic model. And so back on the free clinic model, all your money's got to come in from outside, from the community. And so, you know, you got to have that team that's going to help you tell the story and help you raise the money. So on the charitable clinic side, probably 80% of your money or more is going to have to come from the community. But you can bring in some revenue from your patients. Joe, what percentage of your operation?
3% are coming from patients.
33?
Yeah.
That's higher than normal.
And we keep the administration low.
Yeah, right. And so when you are accepting a fee, there's two camps. I mean, there are two very solidly passionate camps. The free clinic camp is the belief that money should never get in the way of access to health care. And so we don't want there to be any kind of barrier to care. On the charitable side, people think you've got to have some skin in the game. You know, you're going to respect your care more if you've made a contribution to receive that care. And there's research that agrees with both of them. And so, you know, who do you believe? It comes down to what is the philosophy of your group. And there's no right and no wrong answer. Nobody's going to sit in judgment of you for whatever model you choose. But you got to make that decision about which one you're going to be. And so in the charitable clinic, you've got to have a little bit more administrative help because you got to figure out how to handle money and what to do with it and how to, keep track of it, how to keep it from getting stolen. On the free clinic side, you can ask for a donation. You can, at the end of a visit, give them a super bill that says, this is the value of the care that you received. Would you like to make a contribution for the next patient to come in, that's coming in? And that's perfectly acceptable.
And I know what happens in terms of malpractice with a free clinic. How does that get handled in the charitable?
Malpractice in the charitable clinic world is you buy it. Yeah. And thankfully, we've got some brokers that understand the nature of the work that we're doing, and so it's not as expensive as if you were just in a private practice, seeing probably Medicaid, Medicare, and insured patients. Between $6,000 and $9,000 a year in most places. Tennessee has a really good rate. An organization that really is focused on supporting the free and charitable clinics around insurance. And I think they pay like $900 a year for professional liability. So if you're in Tennessee, you need to explore that. Some states have sovereign immunity where if you are using volunteers to treat patients, they can qualify for that kind of immunity. And so there's some restrictions about whether it covers staff or if you have to be a free medical clinic to do that. It differs by state. But and so the next step on the pathway is a hybrid clinic where you're doing some billing. You might decide to bill Medicaid. You might decide to bill Medicare, or even you could in essence be a not-for-profit private practice that's billing just about everybody. And so that's going to add another level of administrative need because that billing services, the collection process is just going to be more involved. You still will have to raise money in the community. It's very rare that you see a hybrid medical clinic that is not having to do some community fundraising to help offset the care that they're given to the uninsured. And then there's the FQHC lookalike. FQHC, the lookalike has to do everything that the FQHC does, which is a lot, but they don't get the federal dollars in grant funding that the FQHC receives. And so there has to be money to start new FQHCs. And right now, for the last 3 or 4 years, there hasn't been new access point money. They keep hinting that it's coming, but that has not happened yet. It's very competitive. I always say it's, the climb to get to the FQHC level is a really steep and hard mountain, but there's buckets of money on the other side of it. And so knowing from the get-go if that is your aspiration will make a difference in how you get started. And so we can go into more depth individually or one-on-one if you are interested in doing that. But you've got to choose who you're going to be. Here's one of the first major hurdles that we run into in helping folks start a clinic. I firmly believe that you need to have your own not-for-profit organization. And it's a fair amount of trouble. And so, I get questions from church sponsors, let's just operate underneath the church. And I've covered that a little bit, but you don't want to risk the assets of your church. Other churches might not support you financially if you are operating underneath the umbrella of your church. Most private foundations don't write checks to churches. And, pastors leave. And pastors have sometimes their own focus on what it is they think is important. And the current pastor might be gung-ho and really supportive of the work that you might be doing. Your future pastor, we don't know. And so if you are a separate not-for-profit organization, you don't care. You love the pastor's support because that generally, means other support, but they don't have the power to shut you down. They don't have the power to, say that this is not something that we think is important, because you've got a separate entity with its own board of directors and so forth. And so the other time that we run into this is when we've already got an existing not-for-profit organization that's operating. And so we can add a medical component to that. Done it several times. But there are some challenges to it. And so, the board of that organization has to understand the risks that they are undertaking with adding a medical component to, let's say, a homeless shelter. You just build in the firewalls with insurance, basically, for that. And so will the board of the clinic will the board of the organization support the work of the clinic? That's always a question. And how is it going to fit into the organization? And so those are just sort of detailed questions that have to be answered if you already have a not-for-profit entity and you want to add a medical clinic to it. You might actually need to change your bylaws to reflect the medical operation. And so it is so much of a hassle to start a new nonprofit. If you're doing medical care, there's the IRS requires that you fill out this form called 1023, and then there's a Schedule C. And that's the real meat and potatoes for this work, because they think they can't really differentiate between a primary care clinic and a hospital. And so the form is really about starting a hospital. But you go through the hoops, and that's why having your team, having an attorney that's in your Rolodex, having a CPA to help you with this process is required. Or at least it makes it easier. I always volunteer to look over 1023 applications before they're submitted, because I've seen enough that I know which boxes, if you check that box, then they're going to kick it out. And it's going to make this process of approval even longer. And so the IRS is going to take anywhere from, I think, maybe 3 months is the fastest I've seen in a long time, to a year to get a response to you. And so as you're going through this process and you need to raise money, once you submit your application for not-for-profit status, you can pretty much bank on the fact you're going to get approved. It's just a matter of when. And they're going to backdate the approval to when you submitted it. And so I always tell people you can begin raising money in the name of the new entity once you submit that application to the IRS, and you get a letter back from them saying, we got it, because it's going to happen. And the only people that aren't going to be able to support you are the foundations, because the foundations are going to want that letter that you get from the IRS that says you are official. But individuals, other churches, a lot of businesses, smaller businesses, don't ask for that letter, basically. And so you can begin to raise money even before you're open, once you submit that application.
Question on that piece. Can you start a bank account then?
Yeah. So, I didn't say it, but step one is you create a corporation in the state where you live. You get an EIN number. And when you start, you have to identify probably 3 individuals as board members. And I'm going to cover this in a little bit, but just sort of getting those initial names on your formation will allow you to get that EIN number, open a bank account, and so forth. And so I'm going to digress into a little bit of the weeds here. Some states have a Corporate Practice of Medicine Act that we have seen sort of raise up and be an issue. Texas particularly. Got anybody from Texas here? Good. California. So yeah, California, moved to Nevada. It's a real challenge to get a clinic started in California. But in states that are rigorous about their corporate practice of medicine, you may have to create parallel organizations. You might have to create the nonprofit that's going to raise the money and then create a professional association that just has physicians on its board to be able to integrate with the practice of medicine. But that's a detail point where that attorney can really come in handy. So your board of directors is really going to be the organization that's going to survive after you start your organization. Your planning team that I've really spoke to in the beginning about those skilled people that are going to help you get started, that planning team is going to go away once you open your doors. There can be crossover between the planning team and the board. I mean, you can have people that are that raise their hand and say, we want to be board members once you're open. You also may have folks that say, I just want to serve. I just want to be a provider. I want to be a nurse. I want to be a dentist and see patients when you're open. And I believe there needs to be a pretty solid line between a board member who's in a governance and supervision role and a volunteer who's actually seeing patients. Because there's some potential for some cross-communication. If I'm a board member and I'm also volunteer and other volunteers and even worse, other staff people know that I'm a board member, then there's a pathway for going around the leadership of the organization, an easy pathway. I mean, it's there already. I mean, there's any staff person can probably reach out to a board member by telephone and complain about the executive director. But if they're a volunteer in the clinic, then it's just like, hey, let me take you back here and let's have a cup of coffee and I want to tell you how bad this guy's doing. And so I really believe that having that separation between board and people volunteering is important. But it's really hard to do at the beginning because the people that are passionate about doing this want to be involved. And so I'm just sharing my opinion with you. I'm not telling you what to do. But I've seen it go bad with board members and volunteers being the same. Because it's not understanding the different roles that they are in and different hats that they're wearing.
So your sense is that someone who is on the board should not end up volunteering at all?
Ideally, I think that is the best way. And there are people that are just as passionate about, there have got to be people that understand what we are doing on the board level. And so I really believe your board has to be, they have to come, they have to visit, they have to sit in, they have to shadow. But providing that hands-on care and so forth, I think is a potential problem. Now, it's done successfully because the board has been trained on their role and understanding the different hats they're wearing when they're sitting in different seats. And so it can be done. But, you know, I'm sort of laying out a best practice model. That is my opinion. And so, you know, I say I've got the curse of the consultant. That I can cajole, I can tell you what I believe, I can help you see what other people are doing. But this is your baby. This is your organization. This is your board. And so you guys have got to make the decisions. And so I really believe in board training and orienting board members to, first in recruiting board members to lay out the expectations of what are you asking people to do. And so if anybody needs an application with an expectations document attached to it, reach out to me, I'll share that. Because as you're recruiting people, you really want them to understand what you're asking of them. And then you want to orient them to, what is our organization? What's our mission? What is our purpose? And so forth. And, in the very beginning, those folks are probably going to set the mission for the organization. And so, having them understand their role is really very important. So I worked with a lot of groups that start with just a bunch of volunteers, just a bunch of committed people doing this work without any kind of paid staff. And that is the least expensive way to do this because staff drives budgets. And we have found after doing this a bunch of times, the sooner you can bring a paid staff person to the project, the faster you're going to get things done, and probably the more sophisticated you will become sooner. Because having a dedicated person focused on, getting the things done, just makes it faster. If you're asking volunteers who have a paid job to give you 3 or 4 hours a month, that's what they're going to give you. If you've got a paid person, even if it's part-time, that can really speed the process along. And so, I would recommend that you build your budget to include that staff person pretty soon after hopefully before you are open. And I can't stress enough that it's important to actually jump through the hoops of trying to find the right person to do this. I know lots of folks that hired somebody from the planning team to be the first staff person. And sometimes it works and sometimes it doesn't work. Actually finding someone that understands, developing that list of responsibilities and then hiring to that list of responsibilities, job description, is important even in the earliest stages of getting an organization off the ground. And so, we talked a lot at this conference about, is God in our work? And so, I can't stress enough the being prayerful as you are searching for the right people to come alongside your team. And it's hard. We particularly in the South, people know the words to say that sort of give the impression that you're churchy. But do they have that commitment? Can you point to something in their life that makes you believe that this is, an individual with the kind of strong faith and dependence on God that we're looking for? And that's just, it's a hard process. And we get it wrong a lot. But, we're broken people, so we keep praying and do it again. And you remember when I said that this was hard at the beginning? This is hard, okay? And so that's why I really stress that call. Because if you aren't called to do this, then blessings to you. Go work for somebody and make a difference in doing that in your community. But if you're going to go down this road of doing starting something new, you're going to need that armor that we've heard about, the breastplate and the belt and the sword, and I don't know the scripture, I'm sorry. You know the one I'm referring to. because, our enemy doesn't want us to succeed here. And so there's going to be things that are put in front of you that are going to be challenging. So it's perfectly okay to start with all volunteers. Perfectly okay. Done it a lot of times. But there's going to come a point when the volunteers say, we can't do this by ourselves, and you've got to have some staff. And so my point is that if you can get to that decision earlier, it's going to probably make the process easier. Providers. So a lot of clinics start with volunteer providers, and that's pretty normal. To start from day one with a physician or a PA or FNP, basically it just means you got to raise more money on the front end because staff drives budgets. And so a model that's been used by Ethne, for example, in Georgia, where 4 physicians that did their residency at Christ Community, I think in Memphis, they all moved to Clarkston, Georgia, and they all got on with the local hospital. But they work 7 on, 7 off, and now they're like 7 on, 14 off. And so they sort of got their schedules to where they could, 2 of them would be working and 2 of them would be free to operate Ethne Clinic. And they did not have to depend upon the clinic to pay their salary because they were making enough. I mean, it's a sacrificial commitment, obviously, but they were making enough to support themselves until they could build, the infrastructure and raise the money with Ethne to get it off the ground. Clarkston, Georgia, Ethne, E-T-H-N-E Clinic. Clarkston, which is the immigrant population of Georgia. Evidently, that's where the immigrants are sent. And so I think Ethne has 50 languages or so that they serve. And their staff covers like 17 languages. And so where was I going with that? Be creative in how you can have that staff provider. Because otherwise you're just going to have to raise the money, to provide that level of staffing. And so there's a lot of benefits to having a staff provider. Continuity of care is one of the big issues in an all-volunteer, medical operation. Because having that patient see a different person every time they come in is just not the best practice of medicine. I mean, it's just one of the dirty little secrets of our sector. And so having a mid-level provider as the continuity, many volunteers appreciate that and will not, they don't see, I'm not needed anymore. That's not the philosophy that most of them have. But, you've got to recruit folks to be your providers. If you're going to use all volunteers, you've got to, recruit a significant number of medical providers to fill the slots when you're going to be open. And so that's where, again, having that team, having a medical champion identified early on, this would be a well-respected, a well-known, generally physician, because doctors talk to doctors, pastors talk to pastors, who can open doors for communication in the hospital system, in the specialty clinics, and hopefully use that peer relationship to get people interested in coming to take a look at the clinic and volunteer their time. And so there's probably a lot of experience, around the room about how to successfully do that. What have we got, 5 minutes? 5 minutes. How do we do this with the money? Holy cow. It's scary. You're right. Remember I said this was hard? So we're going to be Christian clinics. God will provide for us. I mean, I believe that 100%. And it always seems the harder I work, the more blessed I become. And so it's a partnership that you're entering into with God. I firmly believe that we're telling our story, we're praising God for our treasures that are coming in. We're asking people to pray with us and to come alongside us. But Dr. Bob probably would disagree with me if you've read his book, and I recommend his book totally. Hope, I can't remember what the name of it is, but Dr. Bob just prays. That is his model, and it has worked for Dr. Bob. And so pray unceasingly and ask people to help. I firmly believe that it is a partnership. And so I would recommend that when you're filling out that 1023 application, you've got to do a 3-year budget projection. And so think hard about, okay, how much do we need and how are we going to raise it? Foundations are typically interested in this kind of startup work. And so explore your local foundations and go out to the state. Don't ask Robert Wood Johnson to fund your clinic. They're not going to do it. But your community foundation might come alongside. Shoot for a 50% of your revenue coming from individuals, because individuals are who have the money. And they do not generally have any restrictions on what you can do with their money. But I mean, there's all kinds of ways to, raise money. Somebody mentioned that they have thrift stores that they run that produces 80% of the revenue for their clinic. There are creative funding mechanisms around sort of a direct primary care model where you are actually taking memberships into your clinic, and you guarantee access to a certain number of people, and that revenue allows you to see additional uninsured folks. And so that's a whole nother conversation. But just be able to think outside the traditional box about how we're going to support our organization. Churches are a great sense of or source for support. So again, vulnerable, ask, pray, ask people to come alongside of you. One thing we know, it's easier with help. So tap into CCHF, tap into your state association if you are, if you have those, because this is a very giving community. It's rare when someone would call up an existing clinic and say, "Gosh, I'm trying to think about how to do this. What can you? I'll come have coffee. I'll tell you why you shouldn't do it." But again, I've got access to resources at no cost to walk alongside of you as you're starting this. If you get there, I'm going to try to talk you out of it when we have our first conversation. So just be prepared for that. Because, did I say it's hard? It's a difficult road. But, there are huge blessings that come from it. Talk to anybody who's doing this actively, and they will tell you it is such a blessing to do this work. But it's hard. Questions? So get my card, call me, send me an email.
Quick question. How long does it usually take to get to FQHC lookalike from start to,
There's no right or wrong answer there. The deal with the lookalike is you have to be able to offer every service that the FQHC offers. And that's a pretty wide scope of service. And you have to be able to have the administrative infrastructure to be able to do the reporting requirements that they have. And so there's some benefit in doing it, because if you're in a state that expanded Medicaid, then you do get a much higher reimbursement rate for your Medicaid and Medicare patients that you're serving. But you've got to have staff and infrastructure to be ready to do it, and staff drive budgets. So, you're gonna need more people on salary to be ready to file that application than if you're a free or charitable clinic, or even a hybrid clinic. And so it's all about how much money can I raise in the community, because that's going to be, how you are able to add staff and grow and increase your scope of service to being ready to file that application. But the lookalikes are not competitive, and so, at least not as competitive. And there doesn't have to be a new access point funding stream for you to be able to submit your application for lookalike status. And so the pathway to full FQHC status many times runs through the lookalike. So you become a clinic, and then you become a lookalike, and then a funding stream comes, and you are known by HRSA, and you apply for the grant, and you've got a better chance of succeeding.
John, I'm going to give a shout out to you. It was 5 years ago that I was here, and I got the conviction to start a clinic, and I didn't think I'd need John's help, but once I started reaching out to John, it's amazing how many emails you respond to within hours. It's amazing. Do you have a form that does this? Yes. I can't. I don't think I've sent you anything that you didn't have a good source of wisdom or impression on. Everybody's even thinking about to take down an email right now, and feel free to reach out to me.
Yeah, because, and visit other clinics and ask them for help, but they don't have the bandwidth that I do to hold your hand.
I wonder if in your capacity, would you consider helping our church at Jericho Road really figure out if this can work?
Sure.
Is that something that you do? Because I feel like it's kind of just stuck.
Yeah.
Because we're different.
It's a different model.
Yeah.
But I'd be happy to be in that conversation. Yeah. So reach out and let's do it. I think I've never been to that part of New York.
Do you ever have issues with volunteer providers not respecting the faith-based aspects of the clinics, or how do you navigate with getting volunteers that are there problems, are there not problems, all that?
Well, your group needs to determine what are going to be sort of the barriers for what does it take to be a volunteer. There are some clinics that require that every volunteer sign a faith statement, a statement of faith. And I personally disagree with that, but that's just my opinion. And the reason I disagree with it is because I believe our clinics are a mission field for our staff and our boards and our volunteers and our patients. And there's many a story of a non-believer or someone from another faith tradition that has come to Christ because they were witnessed to and they saw Jesus' hands and feet every day when they were at that clinic. And so, again, it's a decision point of your organization. And I think there are probably people passionate on the side of we've got to have everybody as and some of them are, you've got to be in this box as a Christian. Not just a Jesus believer, but you've got to be in this box. And, for me, that's just, I'm not going to sign that. And I'm a Jesus follower, okay? And then there's the people that don't have that kind of structure. If your heart is like my heart, give me your hand, which is a very Wesleyan kind of theology. And if you want to be of service in your community to the people that we're serving, we love to have you. And it's just, there's no right or wrong answer, but it's the culture of the organization. And if you're starting that, you've got to set that culture.
And it's not a detailed statement that would make someone concerned that it's almost has denominational or whatever connections.
And by the same token, I believe that we shouldn't be hiding our faith under a bushel. And there are people that are our potential patients that have been hurt by the church or been hurt by people of faith. And if they see your website and they really, if it's just hard. It's hard knowing the right way to be in this world to where we can want people to come in our doors so we can serve them, with the understanding that there are people that are broken and have been really hurt by the church. And so how do we sort of navigate that? And I don't have an answer for you. I'm just sort of putting it out there that it's a thing.
Question to ask.
What is your perspective? So we're a small, and I'm on the board, I'm not on staff, faith-based free clinic in Durham.
Yeah.
And I'm just sort of just talking to people in the last few days, questioning the model that we have where other than the executive director and the medical director, all the other staff are part-time.
Mm-hmm.
And I'm just wondering if that is necessarily a good thing. And I didn't know if you have any thoughts about it.
There's a lot that goes into that decision making. But most of it comes down to how much money can we raise, because staff drives budget.
Well, the reason I ask is I feel like there's sometimes a certain degree of energy and commitment and sort of missional passion, for lack of a better term, that's engendered if you really are immersed in something. Whereas if it's a part-time job and you think the ministry is a good ministry and you agree with them, but it's a part-time job. And so, anyway, that's what I'm getting.
Yeah. Well, I mean, I think you can talk to folks like Grace Medical Home or, any of the clinics that are a good size operation now, but started much smaller, and get some insights about how they maybe thought about when to bring on full-time staff versus part-time staff. I don't think there's any right or wrong answer. It's all, again, many times it's about how much money can I raise. So thank you all. I think are we done? Are we overdone? Yeah. We're cooked. Let's go pray with Steve for safe travel.